A very good afternoon to everyone. I welcome all the speakers and the attendees for this panel discussion. On the behalf of Voice of Healthcare and Zydus, allow me to inform that this is our last and final episode of our virtual series of discussion that we have taken an initiative to mark the Men's Health Awareness Month, which was November 2021, via a series of virtual dialogues. The theme of these setups were Men's Health Forum, Remember in November. The topic of today's session is men's health awareness is lifelong. And to speak about it, we have a very esteemed set of panelists with me, whom I'll just go ahead and introduce. First up is Mr. Sanjay Seth. Sir is ex-EVP at Iffco Tokio General Insurance. We have Ms. Urvashi Prasad. Ma'am is Director, Development Monitoring and Evaluation Office at NITI Aayog Government of India. We have Dr. Vivek Agarwala. Sir is Director and Senior Consultant, Department of Medical Oncology and Haemato-Oncology at Narayana Health, Kolkata. We have Dr. Indraneel Banerjee. Sir is Consultant, Uro-Oncologist and Robotic Surgeon at Apollo Gleneagles Hospital, Kolkata. We have Dr. Chandrakanth MD. Sir is Consultant, Haemato-Oncology at Narayana Health, Kolkata, and Dr. Saurabh Mishra. He is consultant medical oncology at Apollo Hospitals, Bhubaneswar. While sharing his expert views and opinions, Dr. Saurabh will also be leading this conversation from here onwards. So, further, I would now like to hand it over to Dr. Saurabh and please take it from here. Thank you.
So thank you, Kusbu. So this is really a discussion which we all are looking forward to. And to set the ball rolling, the topic for today is men's health awareness that is lifelong. So what is good is that at least we are discussing about men's health. So most of the time what we discuss rightly is about women's health. But it's a good thing that at least now in these forums we are discussing something about men's health. So my role here is to discuss some of the points, and for that I have all my elite panelists and I will be putting them the questions. So first question would be to Dr. Vivek to start the discussion. So Vivek, so it's a hectic lifestyle for everyone, stressful life, everyone has a thing to do and day-to-day habits, they are also there. So with that, now that life expectancy is high, people are living longer. How does one prevent men's related cancer in the later stages of life?
So, Saurabh, this is a extremely important topic that we're discussing, and as you rightly pointed out, we in the current era are subjected to so much of stress due to various reasons in our professional life, in our family life, and because of this stress, we are not exercising properly, we are not consuming a healthy diet, and often we are everyone as a whole are susceptible to various addictions so as to decrease our stress. This is what the common man faces today in the life. There is a lot of stress, they don't exercise, they don't get time, the they don't consume a healthy diet, and then there are various addictions that allures them so that they can decrease this stress, like smoking, like alcohol, like tobacco, like betel nut, pan, and promiscuous behavior. So all these things are, I think, in total, tells us how what are the reasons that are in our control, that are modifiable, by which we can improve our lifestyle. So we should exercise, we should consume healthy diet, we should prevent weight gain, which not only helps us to decrease cancers but also cardiovascular diseases, and we should not subject ourselves to addictions, including promiscuous behavior. I think that sums it up all.
50% of the cancers, even in men also, they are modifiable risk factors are there. So as Dr. Vivek has said, So if we cut down on these modifiable risk factors, there is a chance that there is a reduced risk of developing cancer in the future. So very rightly said. So now, once we are saying that we are having some modifiable risk factors, in spite of that, in spite of doing whatever, most of our patients, they will present with certain symptoms. And it is essential that the clinicians recognize these symptoms so that the cancer is diagnosed early. And when we are discussing about men's health, most common cancers which we think of are the prostatic malignancies and the testicular cancers. And both of these set of patients, when they present, they initially present to the urologist. So at this point of time, I would like to involve Dr. Indraneel Banerjee. So Dr. Indraneel, most of these patients who are coming to you, the prostatic cancers or the testicular malignancies, what are the common symptoms you see when they walk into you in your walk into your clinic? And so how do you think that what should be the message to the public that they should be more vigilant about men's related cancers?
Yes, Dr. Mishra. So, talking about the prostate cancer first, prostate cancer, I would say a silent killer. In the earlier stages, it doesn't have any prostate cancer specific symptoms. The symptoms may be difficulty in passing urine, painful urination, waking up at night multiple times to pass urine, staring during urination. These are the symptoms that can be present even in non-cancerous enlargement, which is not a benign enlargement of prostate also. So anybody who has this kind of symptoms should consult a urologist or uro-oncologist to figure out if there is any risk factors of prostate cancer or not. These are the early stages where the prostate cancer is still in the prostate. But if it has spread to the other parts of the body, it can cause back pain, can cause kidney dysfunction, can cause it can spread to the lungs, causing other symptoms, and also fatigue. These are the symptoms of late prostate cancer. So, if it is still in the prostate, if it is not much symptomatic, then still the patient should go to the urologist for a checkup. The other cancer you have asked is the testicular cancer. The testicular cancer, the good thing about testes is it hangs outside, so you can easily feel it. So if somebody is complaining of pain in the testes and is swelling in the testes, heaviness, or some fluid collection or water collection surrounding the testes, then it can be because of testicular cancer. Again, they should go and visit a doctor or urologist to find it out. The other one which we have missed is the pineal cancer. Nobody talks about it. It is also a men-specific cancer. Usually, the pineal cancer patients present to the urologist late because of the fear of social stigma. So there's a reason if there are some ulcers or lesions that are not healing, there's some pus coming out of the penile area, they should again consult a urologist. These are the symptoms that can happen in the early stages of the cancer.
So thank you, Dr. Indraneel. I think what he is alluding is that there are some early symptoms with prostate cancer, which are mostly the lower urinary tract symptoms. And at this point of time, the urologist and oncologist or uro-oncologist should be involved, at least to rule out if we are dealing with a cancer. Then there are other malignancies also like penile cancers and the testicular malignancies, which should also be looked into. So whenever these patients they come to our clinics, the most important thing is that in these men's cancer, especially the prostate cancers, these usually are disease of the elderly. So elderly population meaning more than 55 to 60 years. So almost that is 60 years is what at the official age at which people retire here from their routine, from their work. So basically when such a patient cancer detection and all, so most important things are funds. So when we are discussing about managing these cancers or about diagnosis, these are costly things. So I would now involve Dr. Chandrakanth, who is a medical oncologist. So Chandrakanth, these patients who are coming to your clinics, whenever you are seeing a patient or diagnosing a prostate cancer patient or any men's malignancies, how do you plan the funds for his treatment diagnosis? What are the aspects you look into?
So exactly, so in a country of ours, where it's a developing nation, so we don't have the facility of 100% insurance coverage from the government itself. So the initiative of arranging finances has to start from the patient himself. So it is very important how we plan our career, like what to study, when to marry, and what about our kids. So similar way, we also have to plan our future health, because the moment we are above 60, our body parts start getting aged. So we have cardiac, we have diabetes, we have hypertension, we have renal problems, there are neurological diseases, and cancer is also a disease that is associated with elderly people. So the most important non-modifiable risk factor for cancer is age. So age becomes irreversible if we don't plan finances, not after the cancer diagnosis, but we have to plan, we have to anticipate that 1 in 4 patients after the age of 70 will have cancer. So we need to plan right from the beginning. We need to uh, have all health insurance, whether it's a government health insurance or whether it is a private health insurance. We need to give top priority for this. So this is for patients who have not been diagnosed with cancer. Secondly, the moment you're diagnosed with cancer, if we have any insurance, definitely that's a very, it helps in taking the best treatment possible, because whatever having said and done, cancer treatment is still an expensive affair. The best modalities of treatment, like even a robotic prostatectomy, or you need to take expensive PSMA therapy or anti-androgen molecules, they're all very expensive, and they're not covered by all insurances. So we need to have a prior planning and anticipate that there is 1 in 4 chance that I will be diagnosed with cancer after 60 years of age. So this planning has to happen along with other plannings. So insurance is a must, and health insurance must be done. And the moment we are diagnosed with cancer, the most important toxicity of cancer treatment is financial toxicity in a developing country like India. So the patient has to discuss transparently with the treating physician as to what is the amount of money he has to spend for himself, right in the initial diagnosis, for tests and further follow-up. And when it relapses, again, what am I supposed to plan? So this whole financial planning has to start not whenever it is required. It has to be started from day one of cancer diagnosis. So this sort of interaction and financial planning is extremely important in a setting where we are existing. Yeah, Saurabh, thank you.
Yeah, Chandrakanth, very relevant points which he has made. What an important statement he made, financial toxicity. So at this point of time, we would involve Mr. Sanjay Seth. So, sir, basically what we see in our routine practice is that almost 50% of these patients, they are paying through cash. So for their treatment, spending out of their own pockets. So remaining patients, they are either supported by the government schemes, and then there are certain patients who are supported by the TPA. So I would like to involve you here. How does someone who is planning for treatment or being diagnosed with cancer, how does he plan the finances for his treatment and forward? Sir, you are muted actually.
Yeah.
Yeah, fine.
Okay, done. Good afternoon, everyone. I hope I'm audible now.
Yes, sir. Audible.
So, talking about the financial toxicity, which was a very nice term used a while ago, and of course, the concern on the financial burden which a patient has to, or rather, the family has to go through for expensive treatments, particularly in ailments like cancer, they can be definitely shattering, backbreaking. Unfortunately, I would like to make a small correction to what was just now stated, that how does one take care of the insurance needs when there is a diagnosis of a cancer malady? Well, unfortunately, insurances are best to be taken before you have had any such ailment diagnosed. You do not go on to dig a well when the house is on fire. You have to be careful with the preparation part for the medical expense emergencies which may arise at any later stage. Hence, to take insurances from an early stage in life is the best part, because when you take an insurance, one, the pre-existing ailments, if any, would not be covered for a certain duration of the policy existence. And two, you may not be in a position to wait for that duration to get your treatment done. So the costs will have to be put on your own as a burden. Insurance will help if and when you have taken a policy in time, in advance, before any medical emergency or ailment has arisen. Now, there's another aspect to it. Of course, there is, ignorance part, there is negligence part, there's also indifference part. A lot of people always keep saying, it has happened to him, it won't happen to me. It is just very unfair to think like that. There is a possibility of anyone, and as just now was mentioned by two of our leading panelists, medicos, that post 60, 1 out of 4 person has the possibility of getting afflicted with some sort of cancer. And of course, the cost of treatment being high. So you don't start preparing for it at the age of 60. Better it is to get prepared even in advance. Even if you have to get prepared at the stage of 60, because a lot of people get the medical insurance or medical reimbursement support from their employers or the government as long as they are working. Maybe post superannuation or resignation, these facilities may not be available. So for them, they have to fend for themselves. Wherein insurance availability from a day or a time reasonably prior to your getting out of that scheme, wherever you are covered from, will be very important and very relevant to have. One should not ignore this. Unfortunately, most of the times the people feel it's a burden on the pocket, it's an outgo. But take it in the overall perspective. God forbid if there is a situational requirement to invoke a claim under the insurance policy, the premium paid is a very small proportion of the cost of treatment that may have to be shelled out by one. So insurance is available. It is the timely contract that you have with the insurance company, which is going to be purposeful, as also I may say necessary. Unfortunately, public health arrangements in our country are so much overburdened that not everyone is in a position to get the treatment of his liking or timing available to him. We have to go to the private medical facilities which have come up. They provide good care also, but of course there is a cost to it, and medical treatment costs being high and regularly increasing is very difficult for one to afford out of his own pocket, howsoever much he may have his savings or his income. So better and best is to depend upon insurance, take it early in life, live with it. Thank you.
So thank you, Mr. Sanjay. So I'll just continue in that part. So as I said, practically speaking, most of our patients, many of our patients do not have any insurance at the time of our diagnosis. So just practically speaking, how do you think insurance would be able to help these patients, or is there no way out?
Not having an insurance is definitely not going to provide you any financial support. And as I said, the policies can be taken at any age or any stage. However, there shall be a waiting period for any ailments which may have already been diagnosed for that person or any member of that person's family, wherein in that waiting period, there shall be no possibility of invoking a claim under that policy. As of now, all the policies that we have, they come with a waiting period, except for some customized policies which are issued out to group insurances, usually to the corporate clients. for an individual, there shall be a necessity to wait for the waiting period to be over in case one is already diagnosed with an ailment and a treatment for that particular ailment is to be taken. Policy can be taken. There is no denial of the possible of the policy. One can disclose the fact that he has already been diagnosed. That particular ailment will be kept out of the ambit of the policy for a certain stipulated period of time. Thereafter, that can also be considered as a part of the package for cost reimbursement. But do we have that much of time to wait? Normally not. The treatment has to be taken more or less immediately. Hence, even after having a policy with a pre-existing medical situation existing, it may not be giving you the benefit of the policy for that particular ailment. Having said that, I would just put in a word of caution. Just because somebody may have had a particular situation or adverse health condition should not deter him from taking a policy, because that health condition is only one out of the many. There may be very many other ailments which might crop up. There might be accidental injuries. There might be a fall and damage to bones, which may also require an expense of a substantial order. And the insurances at that stage, even if not taken earlier and taken after the diagnosis of a problem, will be helpful to take care of a whole lot of other problems which may crop up in the course of one's life.
Thank you. We'll keep you in the discussions when we discuss about the modalities of treatments which are not coming under the ambit of insurance in a short time. So now I would involve Ms. Urvashi Prasad. So, madam, just one thing. So many patients are still devoid of the standard of care in cancer treatments. As I said, although we are working in a corporate hospital, we see a lot of patients who are being covered by the government schemes. So in Orissa, we have something like Biju Swasthya Kalyan Yojana, which is by the government of Orissa, which covers up to 5 lakhs of treatment for cancer. And then there are other things also. So because of these many financial constraints, many patients are not even able to continue their treatment, especially for cancer patients, because they have to come frequently for their treatment and also because of the cost of the treatment. So what do you think the government of India is, what have been the developments, I should rather say, in the healthcare for cancer patients, specifically meant for the cancer patients by the government of India?
Right. So before I actually get to the treatment part, because we've spoken mostly about treatment, insurance, etc., I would want to really focus on the public health part as well, because I think that is in general hugely neglected in our health system, and in fact, the whole orientation of our health system is very cure focused, very hospital based. But what we really need when we talk of lifestyle disorders, we talk of cancers, is much more of a public health and primary health care approach. Because we have too large a population, too diverse a population. We cannot simply think of pushing everyone into hospitals. That cannot be our approach. Of course, we need hospitals, we need treatment, because despite our best preventive efforts, there will be some people who will unfortunately develop the disease or who will fall sick, and they will need these services. So, of course, these services need to be in place. But the whole orientation of the health system has to be as much as possible towards prevention, early detection, promotion of healthy lifestyles. And a lot of this has to start young. So, if we think of lifestyles and behaviors, it's much harder to change someone's behavior, when they are well into their adulthood. So we need to start young. We need to start with children. We need to start with youth, adolescents. Even when we talk of something like addiction, that is really the age group that we need to be targeting very strongly. And what all of this needs is a public health approach. So now the government has, of course, over the years launched various types of programs. Even under Ayushman Bharat, we are trying to set up these health and wellness centers across the country, which aim to do exactly this, is to focus on prevention, focus on early detection, and focus on health promotion. But I think to really make this a success, we need strong public health cadres in the states to go alongside the medical cadres. So when we talk of health professionals, we still talk mostly of doctors and specialists. And of course, we need that because we have a huge shortage as well as a quality issue in many parts of the country, especially our rural, remote areas, or even our tier 2, tier 3 cities and smaller towns. So, of course, we need to do a lot of work when it comes to doctors and specialists, but we also need to look at other cadres of health professionals who can play a very important role. And that's what I mean by a public health cadre. Not to just put the whole burden on an ASHA worker or an Anganwadi worker because they are already overburdened. They have a lot of tasks. We need to have an entire cadre in place, which cuts across all the different levels of implementation, which can focus on exactly these kinds of issues, and in terms of creating awareness, in terms of promoting healthy lifestyles, in terms of facilitating early detection, and also addressing stigma. And I think that is something one of the panelists also mentioned. Stigma is something we're always grappling with, especially when it comes to cancers, whether it's for men or for women. We constantly have to deal with the stigma aspects. So I think all of this public health professionals and cadres are trained to do. And so we need to develop these cadres. There are some states in the country which do have some sort of a cadre, but they are really very few at this point. So we from NITI Aayog, we are actually working with all the states across the country to develop these public health cadres to address at least some of these public health, preventive, primary healthcare related issues. So I think that is something I wanted to mention before I go on to the treatment side. On the treatment side, I think there's two major set of challenges that we have. One is the actual supply of services, right? So as I said, that a lot of our services are still skewed. They are still concentrated in certain centers, certain larger urban centers across the country, for instance, whereas as you start going to the more remote or rural areas, to the smaller towns, there's a dearth of these services. So people have to travel long distances, so when we're talking of insurance and we're talking of covering costs, when it comes to something like cancer, there's a whole lot of other costs that we need to also think about. So one challenge is to get these services closer to people. And again, that is something we're working on as part of Ayushman Bharat. We're trying to engage the private sector here also in a big way, because there is a large presence of the private sector in health. Of course, not all of it is organized. Much of it is not organized. Much of it is smaller establishments. But we do need to all network them together with the public health system and see how do we ultimately expand the reach of our health services. So that is, I think, one big set of the work that we're actually trying to do with different states under Ayushman Bharat. The other is on the insurance, which we've also been speaking about a lot here. So one, as I said, we need to constantly look at the scope of the insurance. So, under Ayushman Bharat, we are targeting to begin with the bottom sort of 40% of the population. But here we need to look at what are the kinds of treatments we are covering. Are we covering the necessary diagnostics? Are we covering the other ancillary costs? So, like I said, people have to travel long distances, or their caregivers might need to come with them and also stay with them. So how do we start looking at all of that and make it a much more comprehensive package? That is something that we are doing. We're also looking at the costing. We are constantly trying to provide, inputs on how we can revise some of these packages and the costing. The other is how do we actually expand the ambit of the insurance cover itself? So, it's not just the bottom, 40% of the poorest, but we also in India have what we refer to as a huge missing middle. So these are people, who are not right at the top, and they are also not at the bottom, but yet they do not have a health insurance cover. So these could be regular, self-employed people, people with different kinds of professions, but we call them the missing middle. So we've actually developed, sort of concepts, and we have been developing frameworks in terms of how we can expand the government's insurance program itself to also cover this missing middle. So I think some of those developments you will see in the time to come, and these are all areas that we're very actively engaged with from NITI Aayog, with the ministry as well as with all the states, because much of our action ultimately in health happens at the level of states. So there is a lot of engagement that we have to do with states. So I think in all these areas you should see some additional initiatives also coming up.
So thank you, Ms. Urvashi. I think she has very elaborately explained what the government, the state collaborations, and how to go about diagnosing early these cancers. So the most important thing which all of us agree is that it's best that if we diagnose these cancers early. But is it possible all the time? So at this point, I would like to involve Vivek. So Vivek, prostate cancer. One thing previously 90s we did serum PSA routinely. So do you think screening is a very essential component in detecting prostate cancer at an earlier stage, and has it had an impact in the outcomes in prostate cancer? Vivek, you are muted. You are still,
Sorry.
yeah.
So, um, detecting early is something that has both the physician as partaking to that responsibility, as well as the patient themselves, as well as the role of organizations, social media, everything. It is all about raising the awareness in the society regarding the subtle symptoms. PSA testing and screening is something, again, is very controversial, has been discussed earlier, and is not recommended routinely for the public as a screening strategy, because it's clearly shown that if you're doing PSA screening, then there are a lot of high false positives, and you'd end up doing more prostatectomies, and there would be a lot of patients who would unnecessarily be dependent on diapers and having sexual problems. So but opportunistic screening is something that should be done. And patients, once they are above 60 and they have prostatic symptoms, the lower urinary tract symptoms, should keep a notice of their symptoms. There is a symptom scoring. There is a need for raising awareness. In the US, the common man would have these symptoms. He would know by himself that what is his symptom score, and he would sort of keep track of all these things. And so that is what we need: more literacy to be there in our public, more sensitiveness to their own problems. We have to make them more understand their own body, what the symptoms are, when to go to the doctor. And of course, opportunistic screening by urologists, as well as the general physicians, when they are having subtle symptoms or any clinical cues which are telling that the and of course the age adjusted PSA screening, and the subsequent biopsy that is to be done. But PSA screening for the mass, I don't think we are there at that point currently.
So I think we do agree that routine PSA screening, as of now, none of us are doing, not for all comers. So what Vivek has rightly said, that if you choose the appropriate person, or let us say a patient, so someone who is elderly more than 60 years, has a family history of prostate cancer in the first degree relatives, and some BRCA mutations, these are the patients in whom, if at all we do a PSA, we would rather get a greater chance of reducing the mortality in these patients, rather than if we do routine PSA in all comers. It has, although it detects cancer at an earlier stage, it has not translated into significant reduction in mortality in these patients, because many of these cancers, although diagnosed early, may never have become symptomatic in the patient's course of time. That is how a prostate cancer is. So although screening of prostate cancer is in the practice, but has to be for the right patient. So here comes the role of the urologist. So most of the time, Dr. Indraneel, once we see an elevated PSA level. So let us say it is more than 4 or let us say more than 7. And usually at this point of time, we usually involve the urologist. So what is your take on those patients who come with an elevated PSA to you? How do you work them up? How do you rule out a malignancy?
Before I answer this question, I will have a quick word regarding the previous discussion. Whether routine PSA screening, yes, I completely agree, it's not possible in India. As Ms. Prasad already said, they are trying to involve the primary healthcare system. It should come from the primary healthcare system, if at all, for the routine PSA screening. As Dr. Vivek already said, it should be an opportunistic screening whenever the patient comes to you. Within 50 to 70, you can definitely do a PSA and physical examination for the prostate. And routine PSA screening may do more harm than good for the patients. So I agree that it's not recommended, but obviously screening, if you detect it early, can decrease the prostate cancer rate by 25%. So it's important. But at this point of time in India, I think opportunity screening that we should follow. And regarding your question, if the patient comes with slightly elevated PSA more than 4 or 5, it may be because of prostate cancer, because of urinary tract infection, or prostatic inflammation known as prostatitis, or obviously BPH, benign prostatic enlargement, which is more common in this age group, more than 60. So obviously, what I will do, I will reconfirm it with a repeat PSA, do a finger test for the physical examination if I find any lumps or bumps in the prostate, and if it is suspicious, then obviously we can go for a prostate MRI, look for any lesions. And again, it is clinical suspicion, there's a nodule in the rectal examination or prostate MRI is abnormal. Then again, the imaging studies are not 100% accurate. So we have to do a prostate biopsy, that is taking samples from the prostate under image guided, which is usually ultrasound, and take samples from the prostate and see under microscope to find out whether the patient has prostate cancer or not. But unfortunately, till now in India, most of the patients of prostate cancer are diagnosed in TURP. That is, you just do the surgery of a benign prostatic enlargement and you detect the prostate cancer, which is not the right way to do. So if a patient comes with elevated PSA, you reevaluate the repeat PSA, do a prostate MRI, find out if the patient belongs to the risk category of having a prostate cancer. Then they need a prostate biopsy to exclude prostate cancer, and still, if required, then you can go get a QRP done. Otherwise, the line of management will be for the prostate cancer management. That is the way how we walk up.
So I think what he has very clearly stated is that not necessarily all elevated PSAs are cancers, prostatic malignancy. So there are certain other things. Many times there are false elevations of PSAs. So routine repeating PSA at a second point of time, which is essential to see whether it is true elevation or a false elevation. And then we can work them up. So in spite of whatever we do, most of our patients who walk into our clinic, whether they are urologists or to oncologists, they are in an advanced stage, and that is where the problem lies. So, although we would like to detect earlier cancers, but that is not the case. So Chandrakanth, what is the problem? What is the challenges which you face when you see your patient in an advanced stage of prostate cancer?
So yeah, Dr. Saurabh, as we discussed just now, the cancer is curable if we detect early. So, but unfortunately, when in real practice, when we see majority of patients, even if everybody is aware that cancer is curable only if it is detected early, majority of patients present in an advanced disease. So this is an unfortunate thing. Even though we are aware that we have to go to the doctor and we have to take early treatment, majority of patients do land up in a later stage. So, as we had just a previous discussion, that education, if there is a difficulty in urination in elderly male, I have to go to the doctor as soon as possible. If there is a low back pain that is not getting solved, then we have to think of prostate cancer as a first differential, and we have to go to the doctor early. So these sort of red flag signs are very important for the patients and for the general public to be aware of. A low back pain which is not going cannot be ignored. A urinary difficulty which is not going cannot be ignored. A little blood in the urine cannot be ignored. So these or any reason for unintentional weight loss cannot be ignored. So the community has to be aware of red flag signs of prostate cancer. So when a patient comes early, we have seen in our clinic a simple survey, we can keep the patient on surveillance, or a radical prostatectomy, even we have a robotic surgery nowadays. So the patient is left with a cure, what we call as cure for cancer. So this happens in a very little subset of patients. Leave apart prostate cancer, take pancreatic cancer, take lung cancer, or even breast cancer, majority of them are coming in advanced disease. So education is very important from the media perspective, that these red flag signs cannot be ignored. So now for me as a clinician, when I see a cancer patient who is in advanced disease, it's very tough, not only for the patient, not only for the family, it's also tough for a doctor. So I have to explain him that the moment it is an advanced disease, we have effective therapies for prostate cancer, but he cannot have what is known as cure. He has to undergo a sort of a lifelong treatment to control this particular disease. So, but having said that, if you look into the progress of cancer and prostate cancer in particular, so prostate cancer, we always say, even if it is advanced, when you compare it with a stomach cancer or a pancreatic cancer, a prostate cancer, even if it is advanced, is a good cancer. The reason why a prostate cancer which is advanced is a good cancer is, this cancer is hormone driven, it is testosterone driven. So very important is a patient has an advanced prostatic cancer, even if he has florid symptoms. For example, so many bone lesions, completely occupied by prostate cancer cells. If you get down the testosterone level soon, the patient will have a normal life. So a patient who's in a stretcher, who is unable to walk, has lost his weight, if you have what is known as androgen deprivation therapy, either by removing both the testes or by giving injections, the patient gets back to his normal life. So even if you look into an advanced prostate cancer, we classify this advanced prostate cancer into a disease with limited disease burden and a lot of disease burden. Again, the outcomes of these patients matter. So advanced disease happens, but we shouldn't be disheartened in a disease like prostate cancer because we have such excellent treatment, and just reducing the hormone levels gives us promising results. So again, the take-home message from my side is, you need to be aware of red flag signs and you should not ignore them. Go to the doctor as early as possible. Unfortunately, if you are diagnosed with an advanced prostate cancer, you're not so unfortunate. You're fortunate to have an advanced prostate cancer in comparison to other advanced cancers, because these are hormone driven. We have excellent effective therapies. We are getting new therapies. Monthly, every month we are seeing new cancer drugs coming, and each cancer drug adding life to the patient. Not only it adds life, it also improves quality of life of these patients. So we should not be disheartened for the treatment of an advanced prostate cancer. We have effective therapies. Putting them in proper sequence, we can improve life, and we can also make the patient live well. And finally, adding one last point, because we are discussing in public regarding the resources. So if you come early, the amount of expenditure, not only the finances, the amount of effort you need to cure cancer is less, and the results are phenomenal. So coming early means less expense and phenomenal results. Coming late means expenses are too much of efforts from patient, doctor, relatives, everybody. A lot of health professionals are required, paramedical staff are required, and at the end of the day, you're getting results, but not that good. So come early, less efforts, less expenditure, excellent results. If you come late, even if you put extraordinary efforts, not only from your side, from relatives, from doctors, from medical professionals, the results are there but are not that great. So the key is be aware of red flag symptoms. Come as early as possible to your nearest doctor. Thank you, Saurabh.
So thank you, Chandrakanth. I think your message is loud and clear that early diagnosis is the way to go. And also, you have made a very important point, which will be the next discussion point for Mr. Sanjay. So, the hormone positive, these prostate cancers, even in advanced stages, they are hormone driven. So not necessarily all forms of treatment need to involve chemotherapy. So we have here alternative therapies like hormonal therapy, androgen deprivation therapy. Many of these are in the form of tablets. So what we have seen in our practice is that many patients who are coming with an insurance, they are not getting insured for these drugs which are not chemotherapy. That means suppose it's a targeted therapy or it's an immunotherapy or if it is an oral medications. So is this true, Mr. Sanjay said? So is it that only the chemotherapies are all should be covered by the insurance, or have we gone and included the other modalities of therapies in the ambit of insurance also?
Well, as of now, the insurance support or coverage is essentially hospitalization based. Of course, the things have changed and evolved over the period of time. Initially, without a 24 hours hospitalization, the policy could not be invoked for any benefits to be availed. Gradually, as the type of treatment has changed and improved, a lot of procedures which do not necessarily require 24 hours hospitalization treatment have been brought within the ambit of policy coverages. There are umpteen daycare procedures, and for what you cited just now, say even chemotherapy for that matter, it can be carried out over maybe 4 to 5 hours of daycare procedure at any hospital. That is also considered now as a part of the policy coverage, which was earlier not the case. Now, talking of the further advancement, particularly when referring to the prostate cancer treatment, where it may not require a surgery, it may not require radiotherapy, it may not require chemotherapy, it may be oral medication which can be of purpose to cure the problem or to at least treat the problem for the moment. As of now, the problem is yes, it is not within the direct ambit until unless it is post a hospitalization or a daycare situation which may have come about for the treatment initially. But having said that, with the developments and the changes and the advances coming about, the insurance philosophy and methodology has also undergone changes, and there are possibilities, as I said, in some of the tailor-made policies, particularly for the corporate sectors, the OPD treatment is also covered besides the waiver of the waiting period. Now, that limit is pre-prescribed. It is not a very huge limit usually, because OPD treatments you can never be sure of, because all the 365 days you may have to have some medication or treatment. And with the lack of that sort of data availability or the cost implication towards the premium that it may have, they are still not a cover in each and every policy, particularly for the individuals. But as the time is progressing, the thought process is also undergoing a change. And just as Ms. Prasad had made a mention that from the government side, the things are being looked into to broad base the insurance, to look at the costs, to look at all these. Similarly, the insurance companies and the insurance regulator are also continuously trying to bring in changes which shall be in sync with the requirements of the day. Irrespective of the fact that hitherto they are not there, I expect that sooner rather than later, these sort of medical treatments which do not require a definite hospitalization situation maybe with some specific treatment lines, will also be brought in within the ambit of a hospitalization policy cover, which will then not be named a hospitalization policy. It will only be a pure health insurance. Today, it is a health insurance, which is essentially a hospitalization insurance. So I'm quite sure and confident it may just be a matter of time. Maybe work is already on such policies and on such matters. It may only be a matter of time when such procedures do come within the ambit of the policies which are currently being sold and offered.
So I think it's very clear that as we are going forward, moving forward, we are trying to incorporate more and more therapies in the ambit of the health insurance, and this is definitely a very welcome step for all of us. So we are coming to the concluding part, and here again, the most important thing as we discussed throughout is that we understand that early detection is a challenge in India. So my question would be, final question to Ms. Urvashi Prasad would be, so could you please specify how the NITI Aayog is helping in the same? I mean to say, are there any specific schemes which are ensuring that more and more individuals are coming for annual screening? So we have screening for cervical cancer, we have screening for breast cancer, although prostate cancer not specifically. So what are the NITI Aayog? How is it promoting screening for cancer, and what are the long-term plans for that?
Right. So I think I touched upon some of this in my previous response already, but I'll speak a bit more on it. So yeah, so I think one of the major initiatives is these health and wellness centers that we are focusing on. But as I said, the biggest challenge here is the human resource. Because we've had primary healthcare system as a philosophy in the country for decades. As a philosophy, it is not a new philosophy or even a new policy as such. But what has been challenging for us is really the human resource. And when I say that, I mean not just the doctors and specialists, but the other cadres. If you look at many other countries which have relatively good health outcomes, you would see that a lot of the workload is also shared by other types of health professionals, whether it's your nurses, whether it's nurse practitioners, it's allied health professionals. We have historically not invested enough in all these different cadres. What has happened has been a little more piecemeal, or we've tried to pick up say do something for ashas or anganwadi workers, but it needs a very comprehensive sort of approach, and I think that is what we are trying to push through NITI Aayog. As I said, we work with the states on this because ultimately it is in the domain of state governments to actually develop these cadres, to strengthen them, because they can perform a very important role when it comes to both awareness creation as well as facilitating early detection. So, if they can constantly highlight to people that these are some potential early symptoms, like we've heard, then that can play a very big role. For everything, we shouldn't necessarily depend only on a doctor or a specialist. There are many other types of health professionals who can also come in and actually share a lot of that workload. So I think that is really our effort from NITI Aayog side, to work with the state governments to put in place this human resource base, because without that, whether it is screening at health and wellness centers or whether it is any other type of facilities, they'll only be as good as the manpower that we have there. So we are looking at capacity building, we are looking at building these cadres, we are looking at various parts of how we manage them, right from their salary structures to the incentives we provide to them. All of this, we're trying to do a very, very sort of comprehensive look into the entire HR aspect. So I think that is what is one of our biggest initiatives, and so I think once we see that, we will also see screening taking off at these health and wellness centers in a much, much bigger way and in a much more systematic way. As opposed to it being more, piecemeal, or happening in some states and not happening in others. Because, as with India, there's so much diversity. There are some states which are already doing a very good job. There are others who are lagging behind. So I think because we are here at the center, we're trying to address some of these disparities, and we're trying to work across states and see what good practices we can take from one place to another, and how we can make this work. So I think the public health cadre, the human resource piece, is where you can expect some more developments to come up and happen soon. Yeah.
I think that's a very conclusive way of saying that yes, we are definitely working in collaboration, the government and the private sector, to improve the healthcare and also for the screening, which will be doing in the future in a more robust manner. So we have appropriately, rightly finished in time. So 2:55 p.m. was what was given to us. So if there are certain concluding remarks from any of the panelists, I would be happy to take it. So if anyone has any comments or anything,
Can I have a question, Mr. Prasad?
yeah,
This is
please.
for Mr. Seth. I thought Chandrakanth mentioned about robotic surgery. So what is the insurance status in India about robotic surgery? Some insurance is covering, some are not. And the funny part is if the insurance coverage is maybe 5 lakhs, 10 lakhs, but still they're not covering robotic surgery, which is not that costly. So what is your take on that?
Okay. Again, as I made a brief mention, things are evolving, changes are happening. Hitherto, maybe a few years ago, robotic surgery was unheard of in our parlance here. And of course, the cost was also substantially high at that stage. And when it was initiated in terms of a procedure to be carried out, nobody in the insurance domain had any data to support that where it is necessary. Yes, the doctor's decision is the final and the best decision. As insurers, we honor that. But then there has to be a cost element also to the premium. Depending upon the cost of treatment going higher, the premium shall also be made higher. From that perspective, some of the companies could not and did not consider robotic surgery as a part of the package to be paid out for. However, that situation has changed. You're right, still some are paying, some are hesitant towards it. But I think by and large, most of the policies today, irrespective of the value involved, in case the surgeon so demands and so performs, the prior intimation, if given, particularly in case of planned treatments, it keeps the insurance companies informed and they can in turn get in touch with the medical facility or the operating surgeon to get to know the necessity or possible avoidance of that particular procedure or that methodology, based upon which, once convinced, I am 100% sure insurance companies are paying those claims. I, for one, can say that in my company, where I have worked for about 16, 17 years before I superannuated, we had considered robotic treatment as a part of the policy coverage because we were not excluding it as an exclusion in the policy document.
So thank you.
And
So
on the
thank
same note, if I can possibly, as an insurer, once an insurer, always an insurer, Dr. Chandrakanth made a mention from the point of view of, coming to the clinic or the doctor or the hospital early for, better possibility of treatment and cure. On the same note, for insurance also, I would say, start your insurance early, maintain it regularly, otherwise pay very dearly. Thank
Thank
you.
you. So I think we are coming to the concluding part. So I have few points which we discussed. I will just elaborate on them. So initially in my first question to Vivek, I asked, so what are the things which has to be done for modification of the risk factors? So one thing he very clearly said, exercise, healthy diet, and addictions have to be avoided. That is what is necessary to prevent many of these cancers. So one thing. Number two, he asked Dr. Indraneel, what are the common symptoms which we should be aware of, the public should be aware of. And so regarding the lower urinary tract symptoms, at least if you are having persistent symptoms of the lower urinary tract, we have to consult the urologist. We see a lot of pineal cancer also. We do not discuss much about that. That is a big problem in India, very India-centric problem. And testicular malignancies, as also he said, so if there is an enlargement in the testes, especially in young people, should consult an oncologist to rule out a testicular malignancy. Then we discussed about the health insurance, and Mr. Seth very clearly said that we have to do health insurance as soon as possible, as early as possible to get the optimum benefit. We discussed also with Ms. Urvashi about the commitment of the government and to work in collaboration with the private sector. The emphasis has been on early diagnosis. so that most of these cancers can be treated well and can be cured. Then we discuss the challenges faced by the clinicians when we see the advanced stage cancer patients. And we found that since prostate cancer, it is a hormone sensitive cancer, hormone driven cancer, most of the therapies have been not necessarily chemotherapy, but other forms of targeted therapy. We also found out that the insurance companies, they are also coming forward to support these sort of therapies, and so our patients can be benefited from insurance also. There was a discussion about screening in prostate cancer, and all our panelists, especially all our oncologists and Uro-Oncologists, they feel that routine screening is not necessary, not recommended for prostate cancer as of now in India. It has to be opportunistic screening for the most high risk patient, then only we can give the optimal benefit. So once again, thank you everyone for being there and sharing their thoughts. It was really great moderating this session, and I would like to thank Jidus for organizing this event. And over to you, Khushbu. Thank you.
Thank you.